fatty liver disease. Today he is going to present on case-based management on acute or chronic lung failure.
A very good afternoon. At the onset, I would like to thank IMS Surat for giving me an opportunity to give this talk. I am Dr. Madhur. I am a gastroenterologist and in the Department of Hepatology at Sir Chandradayas Hospital.
See it top.
So this is our Department of Hepatology under the guidance of Director Akash Shukla. We are a team of 4 consultants and mentors from UK and France. So after having gone through all the advances in the last couple of lectures, probably I will be dealing more with the clinical talk. So we'll be discussing about the case-based management of ACLF. What is ACLF? ACLF is acute or chronic liver failure. So we have always known about acute liver failure, cirrhosis, chronic liver disease. This is a new term which has been coined hardly a decade back. So it basically means a patient with a known or an unknown chronic liver disease now presents with a sudden acute decompensation. So that is acute and chronic liver failure. We start with a case. So this was Mr. NB, a 41-year-old male who used to have significant alcohol since more than 10 years. He first became symptomatic in around September 2022 when he presented with jaundice and ascites to the local physician in Indore. At that time his creatinine was 0.9. So in the background disease of background intake, alcohol intake, jaundice, ascites, he was diagnosed as alcohol-related disease, which was a chronic compensated cirrhosis. Jaundice, ascites, bleed and encephalopathy are the 4 decompensation events that we usually consider in any patient of cirrhosis. So he had decompensated by the first presentation. In spite of being told to be abstinent, he continued to take alcohol. He probably went and took some herbal medicines for the jaundice. Unfortunately, it deteriorated. Within the next 3 months, so by December 2022, we again presented to the hospital in Indore with significant development of ascites and pain. Now, whenever a patient, so usually ascites is going to be a painless development of fluid collection. When a patient presents with pain, we suspect that there is some sort of a bacterial peritonitis. So this patient, this time presented with pain, had decreased in output. The investigation, he was stabbed, ascites was stabbed, there was no SBP. By this time, the creatinine had got deranged. And he was started there on 30% infusion, albumin, antibiotics. And after a week or so, since he continued to, he did not improve, he was shifted to our hospital for further management. When he presented to us, he was already in the grade 1 encephalopathy. He did not have tachycardia, but was requiring minimal inotropic support and was requiring oxygen support. Extended renal significant pleural effusion more on the left side. The lab showed a hemoglobin of 6.1, platelets of 93,000, ammonia of 64, PCT procalcitonin of 1.60. By this time, the creatinine had gone up to almost 7.33. The bilirubin was 28. INR was 3.8. So, when we diagnose a case of cirrhosis, usually the 4-5 factors that we need is the bilirubin, the INR, the transaminases, the platelet count, and we usually calculate the MED score and the CDP score, so to classify how severe the liver disease is. So in this patient, the MED score was almost 46 and the CDP score was C30. Now just for our knowledge, so the MED score in a normal individual would be somewhere around, it's an easily available calculator on the net, so it would be around 6 or 8. Once it starts crossing 11, we say this patient is developing a chronic liver disease. Once the patient's MED score crosses 15, we actually advise them that they will require transplant at some point of time in the future. Once the MED score crosses 20 or 25, we in fact counsel the relatives for urgent liver transplant. So beyond 25, we even doubt whether the patient will survive the next 3 months. So you can see this patient had almost 46 score, so which was a very high score. And the CTPC means it's almost like the end stage liver disease. But are we happy with only these scores? So stable cirrhotic who now develops organ failure because the creatinine has also gone up. So So we will not call this as a simple decompensation, but this is what we are now dealing with is an ACLF. So this ACLF term, which was coined in 2013, multiple definitions are the European definition, Asia Pacific definition, a North American definition. But what the envisages is, okay, the liver is cirrhotic, we have complications related to cirrhosis, but other organs have started involving now. So when we have a multi-organ failure involvement in the presence of cirrhosis, this is called as ACLF. Usually it is basically a systemic response, a simple, exaggerated inflammatory response. These patients, definitely every cirrhotic is going to need a transplant for long-term survival. But ACLFs, if diagnosed early, if managed well, will definitely benefit from liver transplantation. So what are the organ systems important? So whenever you have a cirrhosis, you have to consider 6 different organs. So you're starting from the brain. So whether there is encephalopathy or not. Definitely encephalopathy is a part and parcel of liver cirrhosis. But an advanced encephalopathy, so the patient is comatose, grade 3, grade 4, we'll call it as an organ failure. So you have different organ failures. So cerebral organ failure, then respiration. So whether the patient is requiring high O2 support, whether the patient is requiring a ventilatory support, whether for the blood pressure, circulation, whether the patient is requiring inotropic support, we need to maintain a certain map in these patients. Liver, so for only one parameter from the liver over here, it is bilirubin. We know that every patient of cirrhosis will have some sort of high bilirubin, 2, 3, 4, 5 is expected. Now, they have done some logistical analysis and everything and found that anyone beyond 12 will consider it as an organ failure for the liver per se. So bilirubin more than 12. Then coagulopathy. So INR more than 2.5. Here the INR more than 2.5 is not a marker of bleeding tendency, but a marker that the liver has failed and it is not able to produce coagulation factors. Then we have a kidney injury. Kidney injury is very common in patients with cirrhosis who get admitted. So 1.5 to 1.9 we will call it as a kidney dysfunction. Anything beyond 2 or requiring the renal replacement therapy we will call it as a organ failure for the kidney person. So you have 6 organs, a brain, a heart, a lung, a kidney, and along with 2 parameters from the liver, the bilirubin and the coagulopathy. And then we have, if you see the right side bottom, how are we classifying ACLF? So ACLF 1, 2, 3. Definitely 2 organ failures, it is ACLF 2, 3 organ failures, it is ACLF 3. But if we have some sort of renal dysfunction, say creatinine is between like 1.6, 1.7 and any of the other organ failure, we will still call it as ACLF 1. So we have to classify the ACLF and accordingly we have to then decide whether the patient has to be admitted in ICU or can be managed in the ward. These organ failures determine ACLF, but you have to understand that certain other organs may also be involved. So adrenal dysfunction is very common. Patients have what we call as a hepatoadrenal syndrome. So they will have sort of a low BP going on. They may need a corticosteroid involvement. Similarly, they would be significantly sarcopenic. There is a gut barrier loss, so translocation of the transmigration bacteria is very common. So there are certain indications which have been determined. So any patients who is going to need any sort of support, whether it's blood pressure support, oxygen support, or renal replacement therapy, or has presented with a massive bleeding, or is comatose, or is in shock at presentation, should definitely be admitted in an ICU. Someone who presents just with black stools for 2 to 3 days is not hypotensive, is otherwise conscious oriented. Probably you can admit in the ward and then can manage whatever endoscopies and everything from the ward itself. Similarly, creatinine 1.6, 1.7, just needing albumin, terlipressin also, we can probably manage in the wards, not necessarily ICU admissions. And then they have been defined what is the risk of death at the 30 days and organ supports, when will you stop an organ support. So yes, you have admitted a patient in the ICU. You have started all the replacements, the patient is on blood pressure medicine, the patient is on ventilator, patient is on renal replacement therapy, and then he's stuck. And here's the 3 days, 4 days, and then the relatives keep on asking to you, sir, bill bahut bad raha hai, aage kya kare, kab tak chalte rahe? And then what answer you give to the patient. So ideally, 3rd day, you should calculate a certain score. There are certain futility scores also available, the calculators are available. So which will actually determine whether this patient is going to improve or not. And by 3rd day or 5th day, if you calculate the scores and we come to a futility where there is no realistic chance of improvement, especially if there is no organ transplant available in an immediate future, then probably we can counsel the relatives, okay, it's the time that we can probably stop and we just give comfort care for a patient. Every patient, when we classify ACLF, we have to identify certain precipitants. So patient known cirrhosis coming to you in OPD, otherwise doing well for 4 to 5 years, and suddenly one day lands up in an ICU with shock, with whatever respiratory discomfort and everything. So always understand that there has to be a precipitant, which can be a common or a rare precipitant. This is an exhaustive list of precipitants. Most important thing is whether there is any infection anywhere, so which can be in the ascites, the pleura, the pleural effusions, or the pneumonias, UTI or cellulitis. These are the 4 common infections that we deal with. Fungal infections are rare but should always be considered. Then alcohol-related hepatitis. Similar to our patients, so who with a known cirrhosis and he continue to drink. So the alcoholic hepatitis worsens and then he lands up in an ICU. Patient has taken any painkillers for whatever joint pains and everything, develops renal failure and comes to us. So these are the usual common precipitants. And the rare things can be any supertated infections like hepatitis E in a non-cirrhotic, hepatitis A in a non-cirrhotic, the cytomegalovirus, Epstein-Barr virus, DILI. Autoimmune patients can present with an ACLF, though usually they present more as a chronic hepatitis. So any patients whom we have diagnosed as ACLF, so any organ failure involvement in a non-cirrhotic, we call it as ACLF. You identify, you do a basic assessment, so find out what are the alcohol history, find out the encephalopathic rate, check the vitals, and then do the workup. What are the broad management points in the patient? So standard things. So initial fluid resuscitation. This is the first question that always comes to us. What fluid will you use in a patient of cirrhotic? We are always worried, we give normal saline, the ascites will worsen. But yes, if the patient is presented to you in emergency or in ICU, and what we commonly do is we use an 2D co-probe and check the IVC status and see whether the patient is underfilled or overfilled. In spite of there being significant ascites, the patient may be underfilled on the vascular part. So here you may definitely want to give certain fluids. So always it's handy if your emergency department has an echo probe and just get a IVC probe, just put it on the lever and see whether the IVC is collapsible or not. And when the patient is breathing, if the IVC is collapsible, this means that the patient is still underfilled. So in spite of being having ascites, you can give fluids to this patient. You can use albumin. So if you think you have given a lot of fluids and still the blood pressure is not coming up, albumin can always be used. Similarly, when you diagnose someone as a hepatorenal syndrome, albumin is the drug of choice. We generally use a 20% albumin, has to be given out of over 6 hours minimum. See to that you do not give it fast because this patient can land up into pulmonary edema. Antibiotics. So the general protocol would be anytime the patient is presented to be in the ICU or in shock, we want you to take immediately 2 sets of blood cultures and then give at least the first shot of antibiotic. Patient has presented first time to you, maybe simple piperacillin tazobactam can work. But if the patient was already hospitalized in any other hospital and has then come to you, there's been recent multiple hospitalization, then you expect that with the current changing scenario, we are dealing with more of multi-drug resistant organisms. So maybe meropenem would be the drug of choice over here. We commonly use BCID panels also. So once we have sent the blood cultures, if the blood culture flags a GNV or something, we immediately send the blood culture identification. The PCR based identification comes within 2 to 4 hours and it actually gives us what species we are dealing with and the enzymes, the resistant organisms. So we have CTX, NDM, oxafortate, and accordingly if we diagnose those, we immediately go to a higher antibiotic like ceftazidime, avibactam or aspirin. Inotropes. If the blood pressure is low, noradrenaline is a drug of choice. If the blood pressure is well maintained and only the clear renal involvement is there, then totally terlipressin can be used. Now I always used to consider terlipressin as a very safe drug, but over a period of time I realized it is not that safe drug to use. So someone who is 60, 70 year old, without a known cardiac history, I would be still a bit skeptical, whether to use a terlipressin. So if you have a good history, okay, the patient has been previously evaluated from the heart point of view, no major cardiac involvement, then terlipressin is a safe drug to use. But without a known history, or if you know that patient had an acute coronary syndrome in the past, has undergone angioplasty, then I would be a bit skeptical in using terlipressin. Any patient who is requiring high dose of inotropes, noradrenaline or something, we always use the stress dose steroids in an ICU. So standard we use is a 200 mg hydrocortisone as a continuous infusion. So do not worry about the infection, this is a stress dose of steroid. And once probably the norad requirement has come down, the patient has responded, we can always come down on the stress dose steroid. Nutrition is very important. So as a general protocol, if the patient is not presented with the GID and we know about the varices history of that patient, then once the patient is with us, we know a very sick patient is not going to eat very well. So here, we on the first day itself, we insert a RT, a soft Freyta tube or something. And once the patient has stabilized, the nausea development is not much higher, then we start the patient on feeds. Patient who is conscious oriented, even if he is taking orally, the target of our nutrition is going to be somewhere like 2000-2200 calories, 60 to 80 grams proteins, which an Indian diet can never provide. So we always tell the patient, you take orally as much as possible and still we continue to feed from the rice tube. So catch-up nutrition is always going to be there. Believe me, nutrition plays a very important role in the recovery of the patient. If the patient is on a very high NODAT support, we are not going to feed the patient because we assume that digestion, absorption is going to be suboptimal in this patient. Still, we would like to give a trickle feed, so like 20 ml per hour, which can be simple kitchen feeds or simple liquids. So still 20 ml per hour unless there is significant RTS feed. Micronutrient optimization is very important. So always use your multivitamins, your B12 injections, which is very important. We commonly check for phosphorus and magnesium. Acute failure patients, if the liver is regenerating, the phosphate will be used. So we always check the phosphorus and if required, we correct the phosphorus, potassium, electrolyte correction, everything is very important. And then you assess whether this patient is fit for a liver transplant, if there are valid donors available in the family or not. A stable cirrhotic can be evaluated and put on a transplant list, but a patient with LCLF who needs a transplant within the next few weeks, there has to be a family donor. So we check for liver transplantation. The problem is if there is sepsis, infection, then the transplant is postponed for at least 2 weeks. But we keep the patient and the donor worked up for a transplant. So these are going to be the broad management points. Coming back to our case, so he was ACLF3, he started on meropenem, teicoplanin and antifungal also. Antifungal we commonly use when the patient has had a prolonged hospital stay because we expect some sort of, we are commonly seeing candidal infections and they are really troubling us and they are becoming an important cause of mortality. So definitely we're using a lot of antifungals. He was started on SLAG, nutritionally optimized, worked out, had developed some depressed mood, had electrolyte imbalance. His creatinine continued to worsen. We did a renal biopsy in this patient and it was suggestive of severe tubular injury. So after a discussion with the family, with the nephrologist, the intensive care team, we felt that only liver transplant may not work for him. So he was advised a liver kidney transplant. This was almost like day 40 of admission. Wife decided to give the liver, a father decided to give the kidneys. Though he was an elderly diabetic, we still did all the scans and we worked him up. And we went ahead with the liver kidney transplant. So this was the trend, the creatinine had gone up to 7, INR was static, bilirubin was at 28. In the pre-transplant period, we started him on SLAG, the type of dialysis. The dialysis continued in the operation, during the operation, and finally he underwent a simultaneous liver kidney transplant on day 46 of admission at our place. Post-transplant, he had some complications, developed a bleed, had to be re-explored, stabilized, inotropic requirement went on decreasing. And gradually over the next 15 days, the creatinine came down to 1, bilirubin came down to 2. He had, since he was like almost day 60 in the hospital, with very poor efforts, we had tracheostomized him so that he can, tracheal toileting and everything was easy for him. Finally, gradually built him up with a physio rehab, was made to walk and was discharged on POD 18, which was like day 65 of admission. This was like 6 months back, he's on regular follow-up, 6 months fine. He's hale and hearty, not even wearing mask, on minimal immunosuppression and going to work. So ACLF probably we never felt that he could ever survive, but we could get him out of this thing. So just to summarize, a stable cirrhotic definitely needs to be considered for transplant. But someone who presents in an ICU, find out the precipitants, find out whether it is extrahepatic or intrahepatic cause of this sudden decompensation. Manage the patient in ICU with nutrition optimization, look for infection, use appropriate antibiotics. We can always de-escalate. We usually start with meropenem, say if we started with meropenem, teicoplanin, and if the second day the PCID shows there is only gram-negative bacteria, we can always take away the teicoplanin. So you can always de-escalate on the day 3. And always evaluate these patients for a liver transplant, if feasible. Only exception is if this bacterial peritonitis, by day 5 of appropriate antibiotics, we can transplant these patients. For everything else, we may have to wait for 10 to 14 days. Thank you for the patient hearing. Happy to take any questions.
So thank you, thank you. It's a wonderful talk and it clearly shows that if it's a protocol-based management, it really works. So we were able to reach to from day one onwards. Dear, you replace both kidney as well as liver. So protocol-based management is really important. So thank you very much. And
Pardon, sir, I could not hear it. So usually the hepatorenal syndrome, till it is a non-oligouric, we may not need dialysis. But if the HRS can always progress to 88, if the patient becomes oligouric or develops electrolyte imbalance or develops lactic acidosis, we commonly check lactates in this patient. If the lactates start rising or electrolyte imbalance is there, we start this patient on SLED or CRRT, depending upon what the blood pressure of the patient is. If the blood pressure is well maintained, short 8-hour cycles of SLED is fine. If patients on inotropes, we start a CRRT in these patients. And the other indication is sometimes we use plasma exchange in these patients. So coagulopathy, encephalopathy, not on inotropes, we can still use plasma exchange. So for non-oligouric AKI, we will not consider dialysis.
Sir, just
Yes.
we have dialysis machine for CRF people. Is there not such device for liver failure patient?
So a lot of experimental machines have been tried. So we had Mars system, albumin dialysis, single pass albumin dialysis, Prometheus system. Unfortunately, none of them have shown that there is a survival benefit. They cannot replace a liver transplantation. Like a renal dialysis can replace a renal transplant for prolonged period of time. So those survival benefit is not there. So we are now only using plasma exchange as of now as a bridge to transplant. So if we know that we can do a liver transplant in just 7 days, 14 days, and just to manage the coagulopathy and encephalopathy for the time being, we use a single weight plasma exchange. But there is no dialysis as of now. If at all it is there in few centers, it is more of an experimental service. So without an experimental protocols, we are not using that.
in the days to come, we'll have it.
Hopefully.
Yeah. So with this, I request Dr. Diptiben Patel and Dr. Ajit Maheshwari to please come on the stage and felicitate our speaker, Dr. Preetham Kataria and Dr. Rudu.